I think that it used to take 10 years, but with all the reviews now, we should be able to learn that faster. And I think we're going to end up with the stem cell. Now, the question is, does that answer the posterior facet problem? And I think if we're going to do that, we then have to be able to, we need to be able to resurface the facet joints and that cartilage, and that's where we're going to go with it. So the question is, do you do something like over on the left here, where we've got now a cage up front, we've got good instrumentation? Do we go to the disc replacement, or should we be looking at something that really regrows up front? And I think that my perspective is that, that we now can grow cells, and hopefully this is the way I would look at this disease at this time. Thank you.
Dr. Dio, as you know, anybody in spine surgery would recognize that name. He's contributed more to the methods and quality of spine research, clinical research in particular, which is very meaningful to us than any other probably single individual. So it's really nice to have him give that talk.
So the work that I'm going to present is work that I've worked on with Sohail and with two other investigators from our research group. And what I'd like to talk about are sort of a follow-up to work that we did a decade ago. We previously had shown that in the 1980s, spinal fusion rates in the lumbar spine were rapidly increasing. And we wondered if that was still true through the decade of the 90s, and how these surgical rates compared with other surgical procedures. We had found then, back in the 80s, that the fastest rise in lumbar spine fusion rates was actually occurring in older adults, primarily for patients with spinal stenosis. We also were curious about the shift in the past 10 years or so to ambulatory surgery, and wondering how big a shift for discectomy that had been, and what fraction of discectomies were now being done on an ambulatory basis. And then finally, we were able to ask a few questions from these sorts of data about reoperation rates. And in particular, we're curious about reoperation rates following spinal fusion. In many cases, surgeons feel that fusion is sort of the definitive operation and is likely to result in lower reoperation rates than laminectomy or discectomy alone for some indications. And so we were curious to identify whether that was truly the case. The data sources that we're using are a large one called the National Inpatient Sample. It's collected by the federal government on an annual basis. And this particular database has about 7 million hospital discharges included in it. They come from 33 states, so not all 50 states. That's because not all 50 states collect data like this. But they take the states that are available and actually weight the cases to represent national rates. And in fact, the hospitals and states that they do sample actually represent about 85% of all hospital discharges in the United States. For ambulatory surgery, we used 4 state databases. There are far fewer states that actually collect any data on ambulatory surgery, but New York, Florida, Colorado, and Maryland, at least, are among the 8 or 10 that do collect that information. And so we used those states, in part because they're fairly geographically diverse, to look at ambulatory surgery rates. We then used Washington state data for examining reoperations. That was necessary because the other databases don't allow you to link hospitalizations for individuals, but with Washington state data we were able to do that. And then we used the US 2000 census to estimate rates of surgery per 100,000 population, and age and sex adjusting those rates so that the trends that we see can't be attributed really to aging of the population, although that probably has some effect on these rates, as you'll see. So first of all, what's happening to surgical rates here? You can see that starting back here, end of the 1980s and then all throughout the 1990s, lumbar surgery rates are rapidly increasing. The green line is actually numbers of operations. The yellow line is the rate per 100,000 adults. The interesting thing on this graph, I think, is that not only are the rates increasing throughout the 1990s, but there really is a sharp inflection here in 1996 with a steeper trend after 96. That actually coincides with the approval of intervertebral fusion cages. We certainly can't make a conclusion that that's why the rate increases, but nonetheless this inflection does coincide with that event. Now, not only is the number of spine fusions increasing, but the percentage of all cases that actually involve a spine fusion is increasing as well. These are inpatient cases, so this doesn't consider ambulatory surgery, which is mostly non-fusion surgery and mostly discectomy. But for these patients who have mainly spinal stenosis, spondylolisthesis, and disc degeneration, you can see that these are being done on an inpatient basis still, and that the proportion of these cases with those diagnoses who receive a spine fusion was only about a quarter back in 1988, but is now over 50%. So the proportion of all cases with a spinal fusion is increasing as well. Now, let me insert a question slide here, if I may. And the question is, in which age group do you think has had the most rapid increase in spinal fusion rates? Is it the younger adults under age 40, the middle-aged adults, 40 to 60, or the older age range? And it looks like most people guess that it was the largest, or the oldest population. In fact, that's actually definitely the case. If we look at trends for those three age groups, you can see that rates are rising in all three of those age categories, but they're rising rather gradually down here for the youngest adults. For middle-aged adults, they're rising somewhat more rapidly. And in the oldest adults, you can see they start down here almost at the lowest rate and end up clearly at the highest rate. So they don't account for the largest number of operations, but in terms of rate per 100,000, that's where the fastest rise in surgical rates is happening, is among these older adults. If we look at rates by diagnosis and understand that these are fairly crude diagnoses in these large databases, as you can imagine, we have the diagnoses that you attach for billing purposes, and what we've done here is to categorize patients according to their primary diagnosis. So these are crude, and in fact, many of these patients undoubtedly have multiple diagnoses and complex diagnoses, but using the first coded diagnosis, you can see that again, spine fusion rates are increasing for all diagnoses. For patients with spondylolisthesis or spinal stenosis, those are these two curves down here. They're increasing at a moderate rate. And the biggest jump here in 1996 really occurred among patients who have herniated discs or just degenerative discs. Clearly, that's where the rise in rates accelerated most, beginning in 96. Now, if you compare these rates with rates for other major orthopedic procedures, at least, you can see that there are far fewer lumbar fusions for degenerative disease than there are hip replacements and knee arthroplasties going on. On the other hand, the percentage rise, starting in 96 through 2001, was much greater, more than doubled for lumbar fusions, whereas the rates were going up at 13, 14, 15% for hip replacement and knee arthroplasties. Hospital length of stay is similar for these procedures. The average total charge, though, you can see is actually substantially higher for spinal fusion than it is for hip replacements and knee arthroplasties. And if you look at the national bill, you can see that clearly hip replacement and knee arthroplasty still account for larger sums of money, but these are big ticket items, and in fact, spine surgery in general is rapidly becoming one of the most common reasons for hospitalization. Now, when we think about reoperations, you know better than I why patients get second operations after a fusion. There may be infections, technical failures, new symptoms, recurrent symptoms, adjacent segment disease, variety of technical failures. There may be advancing degenerative changes other sites that ultimately result in surgery. But in most cases, repeat surgery has been viewed as an undesirable outcome, and in fact, in many surgical studies, it's used as sort of one measure of outcome and generally seen as an undesirable outcome. And we've used data from Washington State to look at reoperation rates. I should point out that because we're using a single state, of course, patients can migrate in and out, and we therefore may miss some patients. But nonetheless, this is our best opportunity to look at reoperation rates. Now, what I show you here are two curves that show reoperation rates for patients who are having fusion or non-fusion surgery. These patients were all operated back in 1990 and 91, so we have 10 years of follow-up. And the yellow curve represents patients who had lumbar fusions. The green curve represents patients who had laminectomy or discectomy without fusion. And you can see that the cumulative rate of reoperations is low initially for patients who had a spine fusion, but then it actually accelerates here. And from about year 2 on, the patients who had lumbar fusions were actually more likely to undergo a second operation than the patients who had laminectomy or discectomy alone. This is controlling for age and gender and patient comorbidity. Now, if we look at factors that are associated with higher reoperation rates, in a multivariate type of analysis, it seems that spine fusion holds up as an association with higher reoperation rates among patients who have herniated discs and spinal stenosis. But that's not true for patients with spondylolisthesis. Clearly, those patients who had fusions actually had lower reoperation rates. Younger age was associated with a higher rate of reoperation, as you might imagine. Women had a slightly higher rate of reoperation. Patients with more comorbidity had higher rates of reoperation. And patients who had workers' compensation as their form of insurance rather than other types of insurance clearly had a substantially higher rate of reoperations. Now, one of the things that we've been able to do crudely, and this is sort of preliminary data, is to look at what fraction of these second operations were associated with some type of device complication. And we looked at patients who were having second operations within 90 days, assuming that those might be relatively immediate complications, patients who had reoperations between 3 months and a year after the initial operation, and patients who had surgery more than a year, and looked at these ICD-9 codes that are complications of an internal fixation device, and they are codes that say mechanical complication, infectious complication, that sort of thing. It turns out that at all of these time intervals, roughly 70% of these reoperations had a code that suggested that the second operation was related to a device complication. So that seems to account for a substantial number of these second operations. So just to quickly summarize, it looks as if fusion rates are continuing to rise quickly during the decade of the 90s. It seems that that trend accelerated after fusion cages were introduced, and the greatest rise is still among elderly patients. About a quarter of non-fusion operations are now being done on an ambulatory basis, and in fact the overall rate of surgery in the U.S. is continuing to rise, and that's age and sex adjusted. Reoperations for lumbar surgery, I didn't really talk about reoperation rates for hip and knee replacement. Those are about 1% a year, so about 10% after 10 years, as opposed to the 20% rate of second operations for spine fusion. So it's a higher rate. Reoperations seem to be more common after fusions than after laminectomy and discectomies alone, somewhat counterintuitively, and approximately 70% of these fusions may involve complications of internal fixation devices. Thanks very much.